Hello, everyone. It is such a pleasure to share with you some information about eye-brain diseases with a focus on in vivo imaging and functional assessments. I have no relevant financial disclosure for this talk. When we look at a beautiful painting like this, we look at the areas that are most interesting to us, often in the middle, in the foreground, and we make these rapid eye movement patterns. When we look at these patterns, we could generate an attention heat map that indicates what we actually saw. We perform a similar attention heat map when reading, except the difference is the pattern is more stereotyped. It's left to right when reading English and from the top of the page to the bottom of the page. The eye-brain network brings us vision by capturing the visual information and regulating the way that we repeatedly control the eye movement so we could capture this information. The eye works as a high-resolution camera that captures the world using over 120 million photoreceptors. This massive amount of visual information is transmitted to the brain for interpretation via the optic nerve. The optic nerve is a bundle of about 1.2 million axons. This is really our own fiber optic cable. Because this process is so intensive in terms of data and rapid, the eye is among the most metabolically active part of the body. As the eye captures the information and sends it to the brain for interpretation, and then the visual part of the brain sends it to the rest of the brain for integration, essentially we perform eye movement and eye capturing of information. So the eye brings the world to the brain gives us vision, and the vision allows us to have human experiences that are meaningful. In my lab, we perform eye-brain research studies. In a nutshell, we look at factors such as the gene, our environment, such as our diet, and how they regulate our neurons in a healthy state, we call it homeostasis, or in an abnormal state as a result of aging, hypoxia, or other external stressors. These stressors lead to metabolic stress in our body, specifically, not just body overall, but in subcellular compartments. That leads to a decrease in the energy that's generated by a structure called the mitochondria. And some of this stress is manifested by a decrease in protein synthesis. So overall together, that leads to a vascular abnormality and sometimes inflammatory phenomena. Together, they lead to neurodegeneration and vision disability. Patients with symptoms of eye-brain diseases can present with a variety of different problems. They may complain of blurry vision, difficulty reading, difficulty with nighttime vision, or visual disturbances. As a neuro-ophthalmologist, I sometimes see patients who are missing part of the vision because of a disruption in the eye-brain network. So sometimes, even if the eye, the camera, captures the information perfectly, it is not being transmitted to the brain for interpretation because it is interrupted due to an optic nerve disease or interruption in parts of the brain affecting the visual pathway. The neuro-ophthalmologists often look at multiple different parts, including the eye movement control, the visual processing, and the pupil control. These are the three components that could go wrong and develop some type of visual disturbances. As a neuro-ophthalmologist, we perform an examination of these three systems. For example, we may start by measuring your best central visual acuity. And to do that, we need to make sure that you don't have any refractive error, because these are optical issues causing a blurring of the vision. We will then check the pupillary light reflex, which is exemplified here. Anterior portion of the eye to check whether dry eye or cataract, which are two common optical issues, may be contributing to the visual disturbance. We then look at the back part of the eye, the posterior segment, to look at the optic nerve and the retina. And sometimes we may find explanations for why there are visual problems in a patient. For example, the optic nerve could be atrophic or thinned, or it could be swollen. Sometimes we use auxiliary testing such as visual field studies or brain imaging to see what is the explanation and the pattern of the vision loss. For today's talk, I'm going to give you a summary on the state of in vivo imaging of the human eyes. We'll go over some cases of optic nerve diseases, and then I will end with a brief summary of our research. To image the back of the eye or the most anterior portion of the brain, we use some fancy imaging modalities. These are done often without dilating the patients, although with the dilation, we often can get even better images like this one, for example. So this is a picture of the optic nerve, which are circular looking structures in the right eye and the left eye. You could also see some really nice blood vessels, an artery here, for example, or a vein here. When we look at the optic nerve and the retina, we describe multiple different features of it that represent how healthy the optic nerve is. The relatively dark and not very striking looking structure that I'm pointing to is actually the center of our vision. This is an area called a macula, which contains a concentration of photoreceptors that could capture vision and serving as a camera. The blood vessels, such as the veins, are pointed in arrow there. We can see what's called spontaneous venous pulsation, which is an indicator of the intracranial pressure relative to intraocular pressure. And if we could see the presence of spontaneous venous pulsation, that means the brain pressure is normal at that moment. Here is an example of the image of the back of the eye of a healthy person versus somebody with diabetic retinopathy, a feared complication of diabetes mellitus. This can be related to type 1 or type 2 diabetes. And what you see in cases of diabetic retinopathy are areas of hemorrhage, which are small punctate spots in red here, or a larger one underneath, and exudate. These are leftovers from previous swelling of and leakage of the blood vessels. Here's a video of the spontaneous venous pulsation that shows what that looks like in patients as we visualize the back of their eyes. With eye imaging, I showed you some examples of color fundus imaging. And we now also use another modality called optical coherence tomography in the last 10 years, which allow us to do very high resolution imaging and quantification of the optic nerve and the retina. Here is an example of what the optic nerve looked like as it's coming out of the eyeball using a technology called enhanced depth imaging with optical coherence tomography. So there's an illustration of the bundles of the optic nerve, as I mentioned earlier, 1.2 million axons making approximately 90-degree turn to come out of the eyeball. they form these bundles, and you can see these really nice tracks showing that the optic nerve is coming out right at this location of the eyeball in a healthy nerve. In contrast, an optic nerve with a structure called optic disc drusen, which are calcified deposits interrupting the optic nerve, may look like this, where there are dark areas which are concentrated and doesn't reflect light, surrounded by areas of these brighter borders, essentially indicating an unhealthy optic nerve, and there may be some interruption of the information going through this area. This is an example of a patient with left-sided vision loss. This is seen in each eye. So there's a shadow in the left eye on the left side, as well as a shadow in the right eye on the left side as a result of stroke. This leads to an interruption of the visual information so that the optic nerve and the brain, essentially an interruption of the visual pathway, leading to vision loss and inability to interpret that part of the visual space. In this patient, we also see a thinning in the retina corresponding to area of the vision loss. Because, as I mentioned before, the visual eye-brain pathway is incredibly connected. And so vision loss could lead to degeneration of that visual pathway in a way that can be measured and quantified. The pattern, in fact, of this retrograde degeneration can indicate where is the location of disease. Specifically, if an optic nerve disease leads to a unilateral thinning of the eye in the eye that has lost vision, a condition due to compression of the optic chiasm, we call it a chiasmal pattern, could lead to some binasal thinning of the retina, indicating that the crossed visual pathways are affected. And then a homonymous hemimacular thinning, such as this one, in a patient with right-sided visual loss, it leads to a pattern of thinning that is in the same visual space as the visual field. Putting it together, the long-distance degeneration of the eye-brain network could occur as a result of disease affecting the eye-brain network. In fact, this degeneration could occur in a retrograde fashion, meaning opposite direction to the direction of the information transfer. So an optic nerve problem such as optic nerve ischemia or glaucoma can lead to thinning within the eyeball and loss of the neurons that represent that visual space. It could also lead to anterograde degeneration into the brain. Similarly, optic nerve lesions, the opposite would be a brain lesion, such as a brain stroke affecting the visual part of the cortex. It could lead to degeneration in a retrograde fashion through a synapse, through the lateral genicular nucleus, leading to thinning in the eye. This is something called transsynaptic degeneration. So the eye-brain network is quite connected for not just structural, but also functionally in order to bring us vision. To image this pathway, we could use the OCT to image in high resolution, essentially nearly 10 to the minus 6 meter resolution, or we could use an MRI to image the brain itself, which is at millimeter resolution. Now we could use another modality of the optical coherence tomography called OCT angiography in order to analyze the blood vessels inside the eye. This is a OCT angiography where you can show the large blood vessels as well as the capillaries that are actually the small blood vessels that perfuse the eye itself. This is a side-by-side view of a color imaging on top versus the OCT angiography on the bottom. So in both cases, these are from the same patient. So in both cases, you can see the large blood vessels like this artery, and you can see the artery here. But in the color imaging, you don't see any of the small vessels, which are capillaries. In addition, with OCT angiography, we're able to not just scan the blood vessels, but we could quantify them in a layer by layer manner. So this is another example of OCT angiography of the macula, which is next to the optic nerve. And you'll see that we could segment different layers of the retinal vessels. So the retina blood vessel is a bit like a peanut butter jelly sandwich with two blood supplies, which is equivalent to the bread, one on top, one on the bottom, and there's some in the middle as well. So by doing the imaging, we could actually have a high resolution representation of the vascular health of this individual. Here's an example of someone with type 2 diabetes and imaging of the optic nerve. Here's another patient with diabetic retinopathy and abnormal blood vessels, which we could again image in high resolution. This is a macular vascular imaging of somebody with diabetic retinopathy, which shows that there are areas of loss of vessel and some irregularity of this central area, which is the fovea. So if there are abnormal blood vessels and blood supply to the center of the vision, this patient is more likely to have some visual disturbances. We can look at the blood tests of these patients relative to the severity of the diabetic retinopathy. And the retina is what we call an end organ, meaning it's one of the last places that receive the smallest blood supply in the body, just like the kidney and the peripheral nerves in our leg. So these are indicators of the human health as a result of diabetes and the damage that the metabolic and other stresses occurs as a result of diabetes. So let's do some cases. First, we have a 28-year-old woman with visual disturbances and severe headache. This is something that's been happening for quite a while, but gotten worse over time. She doesn't have any specific active vision issue on the day of the clinic visit. However, she noted that when she was pregnant 5 years ago, that she did develop some symptoms. This is her vision test result. Her visual acuity was 20/20, which is very good in both eyes. And her visual field test showed that there's some enlargement of the blind spot, which is basically the location where the optic nerve comes out of the eyeball. We see on the fundus color imaging that the optic nerves are very severely swollen on both sides, and there's a bit of wrinkling of the retina next to it, as well as some hemorrhages. And we can't show it to you, but there's loss of spontaneous venous pulsation, indicating an increase in the brain pressure. So this is kind of a no-brainer. It's a bit of an emergency. There's a high brain pressure causing swelling of the optic nerve, and the optic nerve is in danger of irreversible vision loss. So this patient had a brain imaging study, which was not revealing, meaning there was no tumor, there was no aneurysm, there's no hemorrhage, and the blood vessels are open. And so she was diagnosed with something called idiopathic intracranial hypertension, or IIH, which is swollen optic nerves as a result of elevated brain pressure, but not associated with a tumor or a specific etiology. The symptoms of elevated brain pressure could include headache, which is the most common symptom, transient vision loss or blurring of vision, a ringing in the ear or pulsatile tinnitus, other symptoms such as double vision or neck pain. And this is certainly an emergency. And with eye imaging, we can look and diagnose patients who are at risk for severe vision loss as a result of brain pressure. These are 3 examples showing different severity of papilledema. So this one, part of the nerve is swollen, but not all of it. On the bottom, the whole nerve is swollen, and on the right, the nerve is severely swollen, so you have loss of the blood vessels right on the optic nerve itself. There are multiple different types of examples of severe papilledema that we list here. Bottom line is, even though the optic nerve can be swollen in a way without losing vision, papilledema is a neuroemergency. And when we start to see evidence of ischemia and hemorrhage, that nerve could become irreversibly affected, causing permanent vision loss. Fortunately, we were able to intervene in a timely manner. A shunt was placed to decompress the brain pressure by a neurosurgeon, and the swelling of the optic nerve completely resolved. The second case is a 58-year-old woman with painless progressive bilateral vision loss. Her vision was not as good as the first patient. It was 20/60 in the right eye and 20/80 in the left eye, which means she's not able to see the 20/20 line, but the font needs to be larger in order for her to see. In this case, there was no swelling in the optic nerve, which is good. However, there was some evidence of thinning of the optic nerve, especially in part of it, causing a slightly changed color of the optic nerve. We can measure with optical coherence tomography, and we see that there's severe thinning of the optic nerve using this measurement. The thinning also included the neuron that form the optic nerve in the retina, a different measurement for the ganglion cell complex. And this patient did have severe visual field loss. You can see areas that are dark in the left eye and the right eye, indicating that there's already severe vision loss. So it's not just the central vision that was affected, the peripheral vision was also affected. So this is a neuroemergency, and we performed a brain imaging study, which indicated a large brain tumor. This is specifically a meningioma at the base of the brain. And this meningioma, which is typically a benign growth, was slowly compressing and crushing the visual pathway as it goes from eye to the brain. Luckily, this patient was treated in time, again, by a neurosurgeon. And by removing this mass, we can now see where the optic nerve, the optic chiasm, and the pituitary are located on the MRI. So when we talk about a patient like this who already has severe vision loss and severe thinning of the optic nerve, we always wonder, well, what's going to happen to the vision after surgery? For some patients, they just have the same vision. It's just that this treatment led them to not continue to get worse. Some patients could get better, and some patients could actually get much better. So in this case, this is her preoperative visual field test. And within 17 days after surgery, she was already much better. Within 3 months and then 5 months after surgery, the visual field continued to improve. So essentially in the right eye, she has relatively full visual field. And in the left eye, there was almost completely restored visual field, except for some darker areas in the periphery. So this is a successful case where we were able to intervene in time. And so we always celebrate whenever there's a case like this. The next case is a 48-year-old man with left eye blurry vision while hiking in high altitude, specifically at Sierra Nevada. At that altitude, which is 2,400 meters, or 2,400 meter, he was breathing effectively 26% less oxygen per breath and vigorously exercising and hiking. I saw him 8 days after onset of his vision loss. He did have good central vision, which is 20/20 in both eyes, but there is a shadow in the lower portion of the left eye. Color exam of the optic nerve reveals swelling of the left eye optic nerve. And this patient was diagnosed with something called non-arteritic anterior ischemic optic neuropathy, also known as optic nerve stroke, associated with high altitude. An analysis of the blood vessel inside the eye revealed that in the acute setting, there was already dropout of the upper portion of the blood vessels, which corresponded to the lower portion of the visual space. And unfortunately, he continued to lose vision with severe thinning and dropout of the blood vessels around the optic nerve. And in contrast, compared to the healthy good eye on the right side, there was severe vision loss and severe loss of the blood vessels, as well as thinning of the optic nerve. So a little bit about how altitude affect on the health of our eye and brain. At sea level, we are breathing effectively 20.9% oxygen. At higher altitudes, such as Mount Kilimanjaro, almost 6,000 meter, the effective oxygen is 10%. And then Mount Everest, it goes down to below 7%. At sea level, we have no issues. However, even commercial aircraft, they're typically pressurized to 1,500 to 2,500 meter or 6,000 to 8,000 feet. At even higher altitude, we could start to experience some brain and eye issues as a result of hypobaric hypoxia, meaning this decrease in effective oxygen concentration. At very high altitude, these symptoms become much more common and much more severe, especially with prolonged exposure. So I want to talk a little bit about optic nerve stroke, because this is the most common acute optic nerve problem in those older than 50 years old. Typically, the stroke occurs as a result of combination of aging, vascular risk factors like high blood pressure and diabetes, and anatomical factors of crowded and compartmentally compressed optic nerve. Some patients have sleep apnea, which leads to a drop in the oxygen when they're sleeping. In an acute setting, the optic nerve looks swollen, and then in the chronic setting, the optic nerve looks thin and pale. This is leading to a disconnection of the eye-brain network and a vision loss because the information captured by the eye is not being transmitted to the brain. So I hope you appreciate that these different kind of imaging studies and case examples show you how the eyes are a window to human health, specifically vascular health and potentially metabolic stress and changes related to aging and related to vascular health issues. So I want to show you another case which is out of this world. This is a 57-year-old astronaut with something called spaceflight-associated neuroocular syndrome, or SAINS. So this astronaut developed blurry vision in both eyes 6 weeks into his deployment to the International Space Station. This was treated with reading glasses, and he was able to see much, much better in close-up. And the ischemic changes and vascular changes inside the eye went away. However, imaging before and after his second prolonged space flight show that there is some persistent wrinkling of the retina before deployment, and then an exacerbation of the optic nerve edema and the wrinkling of the retina after the second deployment. And some of these changes are unfortunately permanent, and we currently do not have effective treatment for this condition. And it's one of the most important reasons that we're unable to go to Mars or have prolonged space deployment is because of this eye-brain issue. Here's another example of another astronaut who developed some swelling of the optic nerve, which is shown on the bottom compared to the image pre-deployment. And here's another example who developed swelling, and this is a optic nerve image that was taken at the International Space Station, which shows them swelling. And then after return to Earth, we could image these changes even better. And so this is something that is an important and actually turns out not rare condition. So they survey 300 people who have been deployed to space. And many people describe a degradation of visual acuity at distance and near. So 60% on long duration missions, which are typically more than 6 months long, and about 30% in short duration, so 3 months or sometimes less. They specifically describe a decrease in the near vision due to something called hyperoptic shift because of the swelling of the optic nerve and shifting of the retina around it. Some of these changes remains persistent even years after flight. Some of the findings of ophthalmology or optic nerve imaging include optic dysedema, flattening of the back part of the eyeball as a result of the edema, wrinkling of the retina related to the edema, and then ischemic changes such as convolutional spots. Thickening is just a quantification of the swelling of the optic nerve. There's also changes in the brain as a result of prolonged space travel. The brain and the brainstem lifts upwards. There's an increase in the cerebrospinal fluid compartment in the brain. And again, some of these changes are persistent and synergistic with that of the vision changes in the eye itself. They're overall more common in longer duration deployments, almost 50% in those who were deployed for longer than 6 months to the International Space Station. They're present even in those who were having short-term exposure, meaning about 30 days or a little bit longer. The majority is characterized as optic dysedema and then wrinkling of the retina. This is something that is a high initiative for NASA and the space agencies across the world. And so we hope to be able to understand much better what this eye-brain issue in space is due to. Therefore, we could protect our astronauts on the most precious resource, which is their eye and brain function. Just want to show you some pictures of how the eye and imaging can be done in space. This is such an important problem that a lot of instruments have been developed to be able to capture information and for the astronauts to assess themselves in space. So here's an example of a female astronaut taking a color fundus imaging of the back of the eye in space. Here's another example in order to monitor their eye health. The optical coherence tomography that I mentioned, which has millimeter resolution, this has been flown up, including the latest model that has the high resolution imaging of the retina and the optic nerve, as well as the blood vessels. So theoretically, these instruments can be operated by the astronauts themselves to capture information when needed. I want to show you one last case of a 24-year-old woman with new left eye vision loss. This patient has optic disc drusen, which are calcified deposits in the optic nerve itself, and they look very pretty, and they're illustrated here. So 2 years after she was diagnosed with optic disc drusen, she developed new left eye vision loss, and pictures show that there are now hemorrhages compared to the old picture and diffuse swelling of the optic nerve. This essentially leads to a change in the imaging, and I'm showing you two different types of imaging modality here, the color imaging on top and a near infrared imaging on the bottom. So the color imaging is using visible light source, and the near infrared is to use invisible light source, which could give a slightly deeper image of the optic nerve and the retina. And so you could see the swelling around the optic nerve in the acute ischemia, and then thinning and resolution of some of these changes in the chronic setting. We could do some incredibly precise measurements just to show you. This is something called autofluorescence imaging to image the optic disc drusen of using two different visible light wavelengths. This is green light and this is blue light. We could also use optical coherence tomography to visualize slice by slice what the optic disc drusen and the blood vessels look like. So this is a picture that I showed earlier, just another image. We wonder where the optic disc drusen are calcified deposits, kind of like kidney stones of the optic nerve. And we're working actively to figure out what's going on, what causes these deposits, and how we can treat it. Some of the factors may include the anatomy, but also changes such as aging, hypoxia, metabolic stress, and vascular abnormality, leading to the drusen deposits becoming larger and migrate anteriorly as patients get older. Here's an example of a patient who have 3 generations of family who have optic disc drusen, and she's the one that is in red there. So these are her test results and pictures. You can see severe optic nerve swelling due to drusen and severe vision loss, more in the right eye than the left eye, due to all of these deposits formed in the optic nerve head. We could quantify the severity of the optic neuropathy in this case using optical coherence tomography, just like we did in the other patients. This is the patient's brother, just to show that there's another person in the family who also has very severe vision loss and severe changes due to optic nerve drusen. We are inspired by these families to investigate optic nerve diseases and to find effective treatment. So here are 8 pictures to show you different side-by-side view of optic nerve swelling. As I mentioned before, optic nerve swelling is one of the 2 pathologic states of the optic nerve. And so you could get hemorrhages as well as some thinning in the optic nerve itself. These examinations show us how we could urgently diagnose patients in order to institute treatment as quickly as possible. So some of the measurements include visual field testing, structural measurements, vascular analysis, and metabolic imaging. We can now image mitochondrial stress in vivo in the optic nerve or the retina. And then here's another modality where we could use to image the blood vessels. This is a patient with optic nerve stroke in the right eye. And compared to the other eye, in the left eye, you can see that the blood flow into the nerve is diminished in the eye with the stroke. So to put a lot of the imaging together, our goal is to use eye imaging, which is the most accessible part of the brain, in order to understand the severity of disease, to diagnose the disease, and to look at factors such as vascular compromise as a contributor to vision loss. Unmet needs currently in vision research include how do we predict who is going to develop vision loss, ideally identifying them before they lose vision. Number two, how do we protect and restore vision? And there are active studies in the cellular and animal models of the disease in my lab. And then we know there's urgent need for novel therapy. So we are working tirelessly to translate what we discover in the laboratory into human clinical trials. So this is just an example of our pipeline. We have patients or even families with optic nerve diseases. We measure their vision, we image their eyes, but we also perform detailed analysis of their whole genome, their blood, and sometimes we take a little piece of the skin and grow them in a dish for several months. And that gives us very detailed insight into the proteins, the transcription of the DNA and the metabolic status of the cells. The most critical thing is to predict those who are what we call fast progressors, people who are more likely to lose vision, so that we could intervene more aggressively. Even if there's currently no proven therapy, there may be things we could understand that or treatment that we could institute as our best guess in order to restore and in order to prevent vision loss, and potentially in the future, they could be first in line for clinical trials for vision restoration. So to put it together, we are inspired to study the eye-brain network. Our focus is on optic neuropathies and how it impacts the eye as well as in the brain, and how we could, as a result of disease, the visual disturbances and visual dysfunction could occur in patients. And so our goal is to look at our ability to detect and to intervene using novel treatment in order to prevent irreversible vision loss due to optic nerve diseases. I thank you so much for your attention.
So the first question is somebody asking for a friend. Someone was diagnosed with a macular problem. In this case, macular atrophy. Sometimes this could also be a condition called macular degeneration that cannot be repaired. So the question is, how much does this impede the other eye? So good question. So let me actually answer both of them. Let me comment on the macular degeneration. So the macula and the retina, that's part of the brain, which has limited ability to regenerate. And this is why conditions like macular degeneration, glaucoma, optic nerve stroke, it's all about prevention. So it's much harder to try to restore and rebuild something. The macular degeneration that occurs in one eye often could also affect the other eye because there's clearly some factor, either genetic or environmental, that cause the eyes to be affected. And so it's really important for your friend to be seeing a retina specialist for a dilated exam, imaging like some of the ones that I showed you, so we could look at this in great detail. There's certainly some treatment. There's an eye vitamin that many doctors do recommend in order to support the retina metabolically and to prevent the irreversible atrophy. Good question. So there's a question on the most common eye conditions. So I'm going to talk about it. So the question is, how do you treat dry eye? Are there eye drops we should not use? There are so many in the market. So I have a fantastic handout for this, and happy to somehow share with all you. Most I just headache is the most common brain, especially irritated, because that's the only part of our body that's not covered by skin. And so, everything is exposed there. So I recommend some artificial tears that are preservative free. So they come in a little vial and it could be recapped. Things like warm compresses are good. I don't personally recommend the eye drops that make the red of the eyes go away, because they do have chemical in them that could cause the blood vessels to be hyperactive. So I won't mention specific brands, but get the preservative-free lubricating artificial tears and use the warm compresses instead of the ones that says get the red out. There's another good question about myopia. So how does myopia affect your general health as you age? The eye prescription could change over time. Often it changes a lot in people's teenage years, and then around the time starting in their early 40s. And so essentially the key is to see the optometrist for refraction. You deserve which is good for reading, astigmatopia, meaning the irritation to the eyes and difficulty using the eyes to do computer work, to read, and etc. So there's nothing unusual about aging. It's just you deserve to get a good pair of glasses. So definitely recommend refraction and getting some updated glasses as need. I'll combine this with another related question is, after you turn 70, should you get regular eye exam by ophthalmologists? The optometrists and ophthalmologists both are able to dilate the eyes, look at the front and the back, and many of them have the imaging, some type of imaging capability in order to image the back of the eye. I'm particularly blessed at Stanford to have a lot of different kind of, I call them toys, ability to image the eye in incredible detail. And we're really pushing the forefront of imaging and being able to do that. But just run-of-the-mill optometrists and ophthalmologists are completely capable of doing this. And I do recommend the eye exam because, arguably vision is one of the most important part of the brain function. And so you deserve to have good vision. These questions. Okay, so let's do one more. There's a question about concern for radiation expert in the imaging technology. Basically, light wavelength, does have energy in them, but all these imaging technologies that I described are actually quite safe. All of them were done with light that is safe for the human eye, certainly no different than being on a bright sunny day. There's no radiation in the light that is used. And so it's quite safe. There's a light energy panel, essentially all equipment that has to do with light at Stanford is actually regulated. And so you can feel safe that these imaging technologies will not cause any harm. All right, well, I see that it's 8 o'clock, so I want to thank all of you for being part of this wonderful evening. And I look forward to hopefully our path will cross again. Thank you again for coming.